Thank you for joining us for the 4th Annual Global Summit on Kidney Innovation, Global Kidney Patient Voice, the key to accelerating innovation, a collaborative partnership event presented by the American Association of Kidney Patients, the George Washington University School of Medicine and Health Science. My name is Dale Rogers, and I'm an AAKP Board of Director and member of the AAKP Executive Committee and an AAKP Field Ambassador for the state of Idaho. I'm also a kidney patient. I have experienced hemodialysis, peritoneal dialysis, and am a current kidney transplant recipient. 6+ years out, and I also received a pancreas transplant. Diagnosed at 12 years old with type 1 juvenile onset diabetes and later hypertension, the two leading causes of kidney failure today. Advocating exclusively with AAKP with Advocacy Hill Days, participating in advisory boards for industry to provide unique patient insights, and representing AAKP in various federal agencies and also on the SRTR Patient Family Advisory Council to help patients better understand the choices they can make with the transplant centers. Being part of AAKP allows me to share my patient voice in situations where patient outcomes is not always the main topic of conversation. As an AAKP member, you can also do the same. This is critical now that we, as patients, consumers, raise our voices and create the demand for new diagnostics, devices, and biologics in our independent countries. Through AAKP Global, launched in 2019, AAKP is engaged internationally because we are committed to educating patients and leaders across the globe on the importance of kidney disease prevention, new innovations in treatment, and the opportunity to save more lives. We believe that a united patient voice can drive innovation and the policies decisions that determine timely regulations and payments for new and safe care treatments. Globally, we are working with patients, medical professionals, researchers, and medical industry allies to cultivate a united consortium led by patients. AAKP believes this international consortium can advance innovation and change kidney care in countries where healthcare systems and/or infrastructure do not support patients, consumer choice, and/or access to care treatments. For our session, The Future is Here, the Decade of the Kidney and Artificial Organ Innovations in Alternatives to Dialysis. I would like to now welcome another great friend and ally to AAKP, Dr. Victor Gura. Dr. Gura is founder and innovator of the Wearable Artificial Kidney, or better known as WAC. Dr. Gura joins us today to share updates on the innovation. Dr. Gura, the floor is yours.
Thank you so much, AAKP and University of Washington, for inviting me once more to speak to the patients in AAKP. The unmet needs in dialysis have not changed over years. I still have a problem when I tell a patient that he needs or she needs dialysis, And the questions like, what can I expect? How long do I have before I'm gone? Does it hurt? Can it work? Can I work and pay my bills? Do I need help? How am I going to pay for this? And we do not have very good answers today as we didn't have a year ago or 10 years ago to these questions. We have not accomplished too much in the last few years in improving quality of life and reducing mortality. When I talk to patients, the first thing they tell me is, I want my life, my normal life back. That means quality of life. I go to work and go shopping, go out to the family, and that is not that much available to the patients as they would want. The costs of dialysis keep going up, and a billion here, a billion there, it's real money. I'll talk a little bit about that today. The access to care is not that easy to find a place that is convenient. And if you can bring dialysis home, that's great, except not everybody can. Most people cannot. And the care of dialysis is complex and complicated for patients, for families, for caregivers, not only for the dialysis staff. So when we talk about quality of life, what are we talking about? Patients still have cramps very often and they're painful. They're thirsty, but we tell them not to drink that much water. Many of them are tremendously fatigued after dialysis and they cannot do anything else. They all complain of being chained to a dialysis chair all the time. They go a lot to the hospital, they're depressed. We increased the amount of time on dialysis. And when we do it every day or every night, there's less fatigue, there's no fluid overload, they can eat all the salt they want, the blood pressure goes down, potassium is normal, they usually don't go to the hospital a lot, no metabolic acidosis, no high phosphorus, the labs look good, the appetite is good, life is much better or seems to be much better with daily dialysis. But most people cannot do dialysis every day. Very few do that. There's nowhere to do more dialysis units. This has not changed over the years. I spoke about it many times and it hasn't changed too much. We cannot continue building more dialysis units unlimited. Going to home for dialysis is not something that can be increased to any significant magnitude for different reasons, mostly because of very poor technology to implement dialysis at home. As an example, if you have two people in an empty nest with 5 bedrooms, you can put a machine there. But if you have 5 people in a 2-bedroom apartment, you cannot do home dialysis. And you need access to water and space. So daily dialysis at home is not difficult, is not easy, and there's nobody to do it. And also the expense of daily dialysis makes it unfeasible. So we know we need to give patients more time on dialysis, but there's no way to achieve that. If we could do more time on dialysis, there also would be a great impact on the expense of dialysis. If we could do it at home, there would be less hypertension. They would get more dialysis time with no phosphate binders and less pills to eat. And talking about money, a hospital trip to a dialysis unit costs more or is paid at a higher rate than the treatment of dialysis itself. So if we could do dialysis at home with adequate technology, then patients wouldn't have to drive back and forth to the dialysis unit, and transportation is a major problem for every clinic that I know of. Talking about money and pill burden, we still prescribe a lot of phosphate binders. And the charge for phosphate binders is about $1,000 per patient per month. If you do the math, you're looking at more than $6 billion in phosphate binders alone. And we know that if we could dialyze much longer time, we would make phosphate binders obsolete and save billions of dollars just in this one drug. So how do we want to do that? We thought that the building a wearable artificial kidney would be a great idea because it will filter the blood like real kidneys do. If we could filter the blood as real kidneys do, then we could achieve a lot. So we started to build a wearable kidney. First, we tried it in pigs. Then we used it in humans in Italy and in London and in Seattle. Patients that tried our Model 2 of the WAC felt great, could eat whatever they want, potato chips, pizza, cola, ketchup, things that are forbidden today, have a glass of orange juice without any problems. That worked well in 3 human trials around the globe. So the WAC 2.0, we know it works, but it worked because it worked around the globe all over the place. So human trials to prove the concept are done and over with. Talking to patients that used the Model 2 were very happy, but there were issues that they had. It was too heavy. It's not something they want to go out on the street with. So they said, you got to make it lighter and smaller so we can wear it. So we came up with Model 3, and Model 3 is going to weigh only 2 pounds. So during the day is much less obtrusive, and people can do all kind of things, go to work, go to the store, and it's only 2 pounds to wear. It works 24/7, and the light is hooked up to recharge with an outlet and to a stationary module that completes tasks that can be done overnight. So while it is asleep, the WAC 3.0 is working, and you can sleep with it. We hope that this will be something that will give patients their life back. When we have the Model 3, it will allow for several functions to be performed, like remote monitoring. Vital signs could be transmitted. If there is an emergency, it will send a remote alarm. It will allow the doctors to monitor data that we physicians like to see on dialysis patients. Will update medical records, and basically if we are in Los Angeles but you are in Italy, we'll still be able to monitor your data all over the globe. So that is another advantage of the WAC 3.0. And then what's next? Well, talking to patients, they tell me, I want still to be able to take this off. I want to get dressed up and go dancing and go to a party, and I don't want to have this on me when I'm wearing my best fashionable clothes and going out. How can I take it off? And the reason we told them not to take it off was because there was a risk of infection that can be a very bad thing. So if you keep connecting and disconnecting, it can get infected. So we have come up with new technology that will allow the patients to mitigate, hopefully completely eliminate those risks, so they will be able to connect and disconnect when they want. In summary, the wearable kidney is a work in progress. Are there other alternatives that are being built? Yes, of course, and that's good. So I hope I gave you good information. I would be happy to keep the public posted as we make more progress. There will be several wearable versions coming up from different people. That's a good thing. So there will be something for everyone. Thank you so much for this opportunity to speak to you again. Let's stay tuned.
Thank you, Dr. Gura, for a great presentation on your research and advancement in care solutions for kidney patients.